Hey guys, welcome back to my channel Harrison Learns, where we break down complex medical topics into easy to understand lessons. Today, we are diving deep into one of the most critical topics, neoplasms of the lungs, or as we commonly know it, lung cancer. Let's dive in. First, lung cancer is the leading cause of the death worldwide. But lung cancer isn't just a random strike, it is often preventable. What is the primary cause? Obviously, it is tobacco smoking. If you are a cigarette smoker, your risk skyrockets by tenfold increase comparatively to non-smokers. But smoking isn't the only villain. Other risk factors include occupational exposures such as asbestos, common in construction, arsenic, mustard gas, nickel, and polycyclic aromatic hydrocarbons from industrial work. Another one is environmental tobacco smoke, also called as second hand smoke. It's no joke for non smokers. Genetic risk factors. Some have inherited predispositions that make them more vulnerable. But the big takeaway, smoking cessation is very important. Quitting can cut your risk in half within 10 years. Let's talk about pathology. The WHO divided lung cancer into four major cell types, which are grouped into two categories, such as known as small cell lung cancer and non-small cell lung cancer. Small cell lung cancer accounts for 15% of cases, whereas non-small cell lung cancer accounts for 85% of cases. First, we will look into small cell lung cancer. They look like small, tightly packed cells with little cytoplasm, and they have granular chromatin, means the DNA looks speckled, and they have very high mitotic count. Basically, cells divide fast, and they have ill defined cell borders, and they have absent or inconspicuous nucleoli. And remember, the presence of neuroendocrine markers including CD56, neural cell adhesion molecule, synaptophysin, and chromogranin differentiate it from non-small cell lung cancer. Now we will look into non-small cell lung cancer. First, we will learn about adenocarcinoma. It is most common, especially in non-smokers. They form gland-like structures and produces mucin, often in the lungs outer edges, means it is in peripheral in location. Whereas this small cell lung cancer is central in location. And next one is squamous cell carcinoma, shows keratinization, which are hard scaly proteins, and they show intracellular bridges, strongly linked to smoking, usually central in location. And next one is large cell carcinoma, which accounts for less than 10% of cases. Basically, they are big, undefined cells with no clear futures. Immunohistochemistry. If napsin A is positive and TTF1 means thyroid transcript factor 1, if they both are positive, the adenocarcinoma is likely present. If they both are negative, then squamous cell carcinoma is likely present. If in non-squamous, non-small cell lung cancer, they are positive for CK7, cytokeratin 7, and negative for CK20. But whereas in squamous cell lung cancer, it is negative for both CK7 and CK20. Lung cancer can be silent until it is advanced. Symptoms depends on where it grows or spreads. Let's break it down with clinical manifestations. If there is local growth, that is central tumor, then it can cause cough, hemoptysis, wheezing, stridor, dyspnea, or post-obstructive pneumonia. If there is peripheral tumor, it can cause chest pain or dyspnea. If there is intrathoracic spread, it can cause tracheal obstruction, dysphagia, esophageal compression, Horner syndrome, where it causes droopy eyelids, small pupil, and no sweating on one face side. Basically, there will be nerve damage. And another one is Pancoast syndrome, shoulder pain from tumors at the lung top. And there will be diaphragmatic paralysis. There will be weak breathing from nerve damage. If there is extrathoracic metastasis beyond the chest, then it can spread to brain or bones or liver. If it spread to brain, it can cause headaches, seizures, and if it spread to bones, it can cause pains, fractures. If it spread to livers, it can cause jaundice. And then there is paraneoplastic syndrome, especially in small cell lung carcinoma, where tumor cause body wise issues. Basically, symptoms are caused by substances that tumor release, not from direct spread. First, it causes SIADH, where there will be low sodium causing confusion, and next there will be Cushing syndrome, where there will be high cortisol leading to weight gain or high blood pressure. And then there will be Lambert Eaton myasthenic syndrome. There will be muscle weakness basically. Then in skeletal symptoms, there will be hypertrophic osteoarthropathy, basically joint pain or swelling. They are often present in adenocarcinoma. And clubbing, basically fingers are shaped like drumsticks. It often present in non-small cell lung cancers. Now we will look into clinical findings suggestive of metastatic disease. Basically, symptoms elicited in history are constitutional weight loss greater than 10 lb, musculoskeletal pain. In neurological, you can see headaches, syncope, seizures, extremity weakness, recent change in mental status. Signs found on physical examination are lymphadenopathy greater than 1 cm, hoarseness, superior vena cava syndrome, bone tenderness, hepatomegaly greater than 13 cm span, focal neurological signs, papilledema, soft tissue mass. In routine laboratory tests, you can see hematocrit value less than 40% in men, less than 35% in women. There will be elevated alkaline phosphatase, GGT, SGOT, and calcium levels. These are the clinical findings suggestive of metastatic disease. Diagnosis. If you are suspecting lung cancer, a chest x-ray is always the first step. And next, we have to do low dose CT scan for detailed evaluation and for high risk population like who are very heavy smokers and who have like advanced age. And final spread, PET scan, basically they show active cancer spot and they detect metastasis. And next one is MRI, they check for brain or spine metastasis. For confirmation, you need a biopsy, taking a tissue sample. Options are bronchoscopy for central tumors and CT guided thoracic needle biopsy for peripheral tumors and endobronchial ultrasound for samples of lymph nodes and thoracentesis or pleural biopsy for if there is any pleural effusion. And next, if you have to do molecular testing, which is essential for non-small cell lung cancer, to check for PD-L1 mutations or EGFR or ALK mutations, and it guides basically treatment. So next, we'll learn about TNM staging. Staging tells us how far cancer has spread. Now, where in TNM staging, where T stands for tumor size or invasion, where N stands for node involvement, where M stands for metastasis. Please pause this video and remember this, how they categorize this. And basically you have to remember this because it guides treatment and prognosis. What I am trying to say is, if the tumor is in stage 1 or stage 2, then surgery is possible. If tumor is in stage 3, then you have to do for patient surgery plus chemotherapy or radiation therapy. If tumor is in 4th stage, then you have to go for systemic drugs. Please memorize this. And now treatment. Treatment depends on stage and type. For solitary pulmonary nodules, which is small lung spots that is 1 to 6 cm in diameter. How can you say that solitary pulmonary nodule is benign or malignant? For benign ones, there will be a calcification, a dense central nidus, and multiple punctuate foci, and bullseye, which is also known as granuloma, and popcorn ball, which is also known as hematoma, and hematoma calcification, they are highly suggestive of benign lesion. In malignant lesion, there will be irregular borders calcification. Okay. Now, how are you going to manage non-small cell lung carcinoma? First, when you are done with whole diagnosis, then you are going to manage this according to TNM staging. First, even TNM staging, if the nodes present are in N0 or N1 nodes, and if it is in stage 1A, then surgery alone is enough. But if tumor is present in stage 1B, and tumor size is less than 4 cm, surgery alone is enough. If tumor size is greater than 4 cm, surgery is followed by adjuvant chemotherapy. If tumor is in stage 2 or stage 3, then you have to do surgery followed by adjuvant chemotherapy. What if nodes are N2 or N3 nodes? And if you can't do surgery here, you have to do treatment with combined chemo radiation therapy. Remember, combined chemo radiation therapy, you can't do surgery here. What if tumor is positive for metastatic disease? You have to go for systemic medications. First line always depends on biomarkers. If tumor is EGFR positive, we have to go for EGFR inhibitors like osimertinib. If tumor is positive for ALK positive, then you have to go for ALK inhibitors such as alcitinib. And for immunotherapy, if PDL is I, like greater than or equal to 50%, you can go for pembrolizumab. How to manage your small cell lung cancer? If they after doing your diagnosis, then if there is no sign, symptoms or imaging to suggest metastatic disease, then if the patient also has no contraindication to combine chemotherapy and radiation therapy, you can continue with combined platinum based chemotherapy and etoposide and radiation therapy. If patient has contraindication to combine chemotherapy and radiation therapy, then you have to do sequential treatment with chemotherapy and radiation therapy. If patient is positive for metastatic disease, then you have to continue with chemotherapy alone or radiation therapy for palliation of symptoms. Lung cancer is tough, right? But understanding it empowers us. If you love this, smash that like button, subscribe for more Harrison Learns. Comment your biggest takeaway below. Stay healthy, stay curious.